morning, everybody. This is Dr. Sameh Emil from Maadi Hospital Cath Lab. Welcome to ICR case presentations. I wish to thank Professor Muhammad Sobhi and Professor Sadaqa for giving us this opportunity to introduce our case today. I want to introduce my team, Dr. Hussam and Ms. Amani, Mr. Muhammad and Mr. Magdi, the technician. We'll introduce the case right now on the slides and the case. Thank you.
Good morning, dear Chairman, professors and colleagues. We are here today to present our case in Maadi Military Cath Lab. Our patient today is a male patient, 59 years old, pre-diabetic, known ischemic heart disease with previous PCI to LCX and LAD. The last PCI was on 2015. Now the patient complains of recurrent chest pain with mild ischemic ECG changes as T-wave inversion in the anterior leads and typical chest pain. The patient had coronary angio done and it revealed ostial left main, 70% stenosis with proximal LCX stenosis before the stent and another stent in the another proximal stent in the LAD. Now we'll start the case with Dr. Sameh and hopefully we'll do it well. Thank you.
As you have seen from the angio and the data of the patient, we have ostial LAD lesion and proximal circumflex lesion. His Euro score is 0.5 and his syntax score is 22. So we'll proceed for the case now, and the proposed bifurcation technique we'll present here today. Maybe it's a provisional stenting, or we'll, according to the results of the left main LAD stent, we may go to the tap technique. Now we'll have to introduce our catheter into the left main, and we will notice the pressure drop from 160 systolic almost to 60 millimeter mercury systolic. So we'll start by introducing the two wires in the circumflex and the LAD. We have the two PTT wires. We'll take a picture now. And we have a spider view. Okay, another picture in the spider view. And you appreciate the lesion in the ostial LAD, in the ostial left main. So we'll have to dilate first with a balloon 3 by 15, 3O by 15 for the ostium left main. We're now trying to cross the left main with the balloon 3O by 15 just to dilate the ostium and to have okay, the balloon is crossing the ostium now. Please dilate quickly. 2, 4, 6, 7. Wow. As you can see that there is we'll have a picture after the dilatation. think this still there is some residual stenosis. We'll see if the pressure will change. Still the pressure drops again when we introduce. So we'll dilate again. We'll have another dilatation here, dilate. Enough. Dilate. Slip. Okay. Each time we dilate, the balloon slips down due to the high-grade stenosis in the left main. Now we'll see another picture. I think maybe we can go with the IVUS now to see if what's the lesion and what the actual size of the left main at that time after the dilatation. Now the IVUS probe here is in the LAD, and we will start pull back. Okay. Still in the proximal LAD now, in the stent in the proximal LAD are going now to the left main. I think the probe is in the left main now. Okay. So we'll interpret now the picture of the IVUS. The reference diameter of the left main is 5. So we'll go for stenting of the left main LAD with a stent 4 by 18 or 4 by 15. So we'll have a picture in the LAO cranial just to delineate the ostium of the left main. Okay, maybe coded, because we can't delineate the ostium of the left main very well. So we'll have different views in order not to miss the ostium. I think we have to go again to the LAO cranial. I think the position now is reasonable. We can go for the caudal in order to open this thing. No, just open. Okay. We'll deploy the stent now. Yes, yes. You can see the tight lesion here.
16.
Okay, down, please. course, all of you appreciated this tight lesion in the left main. So we'll have a picture now to see what's the result of our stenting. Okay, it's a very good result for the left main now is apparent. We have to have the jailed wire in the circumflex to be withdrawn and to recross to the circumflex again. So we'll withdraw the jailed wire from the circumflex now. Okay. Just we crossed here with the circumflex wire into the LAD and we will withdraw the wire of the LAD, trying to recross into the circumflex. I think there is a TIMI3 flow in the circumflex. I'm thinking just to leave it like this because the lesion in the proximal circumflex I think is not so tight, but we can have an IVUS in the LAD. We just go with the IVUS probe and then we'll have a pull back. Now we are in the left main, I think, in the stent. Okay, so we'll have 4.5 by 12 non-compliant balloon for post dilatation of the left main. As we can see that the stent apposition in the left main is a little bit unopposed, underopposed. So we'll have post dilatation here. This is a 4.5 non-compliant balloon for the post dilatation. We'll have a picture now. Okay. We can have stent phase to see this technology of Siemens, the clear stent technology. We'll see that the dots of the balloon is not crossing outside. Okay, we can go inside a little bit. Okay, just dilate. Okay, enough. We'll go inside again. We'll have post dilatation in this angle. Just dilate. Okay, enough. Fascini. Okay. Pulling back. Okay. So we'll have spider view again, please. I think that the circumflex arteries ostium is okay. No compromisation to my mind, and I think we'll go for this provisional stenting, and we'll end the procedure now with this result. So we'll withdraw the wires and take a final picture. Also, we can appreciate there is no pressure drop when we put the catheter in the ostium of the left main now. And this is our final result. Thanks to my team. We can take another view. Okay. Thank you so much. Thanks to my team, Dr. Hussam, Ms. Amani, Mr. Magdi, and thank for Wissam on the IVUS. Thank you very much.